Hello there. Here's a quick question for you. Imagine there's a stroke patient with features like a stiff elbow, along with a flexed wrist and clenched fingers. Now, what would you write as per your assessment? Would you label it as spasticity? If yes, this is where things get wrong because spasticity is not directly equal to upper motor neuron syndrome. Spasticity is just a symptom. Whereas upper motor neuron syndrome, a syndrome is a collection of clinical features which are produced by a broader neurological disturbance. So, if we reduce the entire syndrome to spasticity, we are basically trying to understand an entire city by studying one single traffic signal. Now, is it useful? Probably yes. But does it give us the complete picture? Absolutely not. So, let us try to understand upper motor neuron syndrome in a bit detail. Upper motor neuron syndrome has two different types of signs. The first is known as negative signs, where something is lost from a pre-injury state. It could be weakness, it could be decrease in dexterity, fatigability, or other things. The second set of signs are called the positive signs. Now, this is where something is excessive or abnormally present. To name a few, we have spasticity, hyperreflexia, clonus, spasms, Babinski. You can have co-contraction, also synergistic movements. You can have spastic dystonia, or let's say associated reactions. So, these are the different types of signs. Now, let us consider an example. Suppose a patient cannot extend their wrist. You check, you assess them, and you say it is spasticity. Now, what is the next step? You try to stretch it, you try to splint it, you medicate it, you try to inject Botox. But is it correct? No, it's not. What should you rather be doing? If the patient cannot extend their wrist, you'll ask a very important question, and that's why can the patient not? Now, there could be multiple reasons. To name a few, first, neural overreactivity. Second could be weakness. Third, soft tissue shortening. Fourth could be loss of motor control. So before calling something spasticity, we should ask what exactly is limiting movement. And that's very important. Now, let us see two different pathways. The patient comes with you with stiffness, you try fast movements, you find hyperreflexia, there is a velocity-dependent increase in resistance to movement, and then you will call it spasticity. The second trial, you're doing a slow movement to check if resistance is still present. And yes, the resistance is still present, it's still noticeable. So, now you should think beyond spasticity. And this is the distinction which really matters. A stiff limb is not always equal to spasticity. There could be neural as well as non-neural factors at play. If we talk of neural factors, there could be spasticity, there could be spasms, there could be co-contractions, dystonia. Whereas if we talk of non-neural fibers, there could be contractures, soft tissue stiffness, reduced range of motion, structural changes. There could be a single or both at play. Now, imagine the two different patients having the same exact clinical features. But still, both those patients can have completely different mechanisms producing it. And this is where the story becomes more interesting. Upper motor neuron lesion causes reduction or decrease in descending control. Now, this can lead to multiple consequences. To name a few, we could have weakness, there could be reduced dexterity, altered muscle tone, there could be abnormal reflexes, there could be decrease in the quality of movement. And finally, all these consequences will cause reduced motor activity, leading to reduced tissue excursion. And this is what causes structural adaptation. And once structural changes develop, the movement limitation is no longer purely a neurological phenomenon. So, whenever a patient comes with stiffness, you should ask what is a limiting function? What is a factor limiting function? It could be neural, it could be mechanical, could be weakness, could be loss of motor control, could simply be pain or contracture, or even a combination of all these factors. So, always remember that spasticity may be part of the problem, but if you make spasticity the entire diagnosis, you may end up treating the examination assessment rather than the patient at hand. So please always remember, upper motor neuron syndrome is not equal to spasticity. This is Dr. Hansla Sheikh. Follow Rehab Dialogue for more.